So I have had the privilege of working with the Cancer Care Quality Initiative this year, and I worked on two main things. One was a risk stratification project, and the other was timely treatment. So we're going to start with the risk stratification. And so as you probably are aware, chemotherapy patients often feel kind of ill after they receive their chemotherapy treatments. The problem is that some of them progress on and their symptoms deteriorate until they need to go to the emergency room or the hospital. And we're hoping that we can use data to prevent this at some point, to trigger some sort of intervention and help reduce emergency department and hospital admissions. So we want to reduce these acute events and also stop the deterioration of symptoms in patients. We need to be able to identify which patients are at the highest risk for these acute events. So we know that we're asking our providers to do a lot of things with limited resources all the time. So we're hoping that we can use these data to link patients to the right resource at the right time. We also have a bunch of different services, available to patients based on their different needs. So, the end goal is to not just be able to identify the high risk patients, but also link them with the right resource that they'll need at the right time. So the goal of this analysis was to, one, validate the Proact, which is a chemotherapy-based risk score, and then to think about generalizing it to another similar model that's a little bit easier to implement. So the Proax score is a score that ranges from 0 to 13, and it's primarily based on the chemotherapy and tumor type combination. And then they also increase the risk if they're under age 45, since young people tend to have more aggressive tumors. And then if the patient has been to the emergency department in the last 12 months, they also get an increased value on their risk score. It's also important to note that right now, at UNC Health, the nurse navigators are implementing interventions. They make a phone call to the patients that have a Proax score greater than 8, but I'm going to show you data from prior to that intervention beginning. Here on the left, we can see what the data looks like from when the risk score from 0 to 13. But for ease of analytic use, and because this is quite jagged data, I actually grouped it into four risk groups, and the two highest, the group 1 and 2 are considered low risk, and group 3 and 4 are the high risk. And those are the groups that if they were these were current patients, they would receive this nurse navigator intervention. So here we can see on the left the rate of, in purple, the rate of patients who have no event, and we see that decreases as the risk group increases. So there are more events happening in the highest risk groups. And this is a statistically significant relationship with a p less than 0.001. We have good specificity, but our sensitivity is quite low. And unfortunately, we also have a lot of false negatives. So that means there's a lot of patients that are identified as low risk, but they're still having acute events. So I know this slide has a lot of data on it, but I want you to focus on the blue row where we can see the event rate. So that overall, 9% of our patients have an acute event within 30 days of their chemotherapy initiation. But within the high risk group, that's 20%, and in the low risk group, it's 7%. So we're identifying patients who are at the highest risk of acute events, but because there's so many people in the low risk group, we're still having a lot of events happen, even though they're identified as low risk. And if you look more within each cancer type, we can see that it's actually driven primarily by breast cancer patients, which have the lowest overall event rate. It's just because there's so many more breast cancer patients than there are other types. So thinking about how we're correctly identifying patients that are at high risk due to chemotherapy, but we still have limited resources, are there other ways we can look at this? So this is kind of how it falls out. We have this pyramid where there's a fewer people in the high risk group, but they are having more events. And in the low risk group, there's events and there's not events, but there's a lot of people. So there's a little bit of both. The question is, the Proax score cut off at 8 was chosen before was chosen. And is that the right the right limit to cut it off? Can we maybe change where the cutoff is to find a better way to identify who's high risk and capture more people? And so we can use the Udens index, which is optimizing both sensitivity and specificity. And we do improve sensitivity, but we at the price of having a huge number of patients in the high risk group. So again, we have a higher rate of events. We have 16% of events in the 16% of the high risk people now have events, and then the low risk group only 3%. That's good, but we have to intervene on way too many people that we don't really have the resources to do so. So what we have here is that the PROACT is predicting well among the patients that it identifies as high risk, because they're at high risk driven mostly by their chemotherapy agent. But there's still a lot of events happening in this low risk group. And the question is, can we leverage other data points to improve the performance in the low risk group? So one thing is we can look at the socio-demographics and comorbidity, which I don't have data for yet, but we can see that there are that the socio-demographics and comorbidity might be driving some of this acute event use in the low risk group. And we see that there's more demographic differences in the low risk than the high risk group. So there could be something driving there that we're still looking at. And here on the right, we can see kind of a tree of how we might use this combination of data to link patients with the right interventions. So for example, if somebody's high risk, they might receive one certain intervention. And then if they're low risk and they're also certain socio-demographic and cancer-related data, we'll put them in a similar intervention. And maybe something else will make us think about putting them in a different intervention. And compared to like overall, everyone who doesn't fall in certain buckets might just have continued monitoring, while patients will be linked to certain interventions and resources based on their data about the patient. So the problem with PROACT is that it's based on chemo regimen and the disease group. So if you can think of how many different tumor types we have and how many different chemotherapy drugs we have for each of those tumor types, there's pages and pages and pages of coding that you have to do to create the algorithm that identifies a patient as high or low risk. So the problem is, as new drugs enter the market or are approved for different tumor types, then you have to go back and recode and add more things to the algorithm. It just becomes kind of cumbersome to implement in practice. So we decided to think about modifying the Proax score that would be by using drug class instead of specific chemo agent and tumor type, to see that it have something that's easier to implement and maintain moving forward. And what we found is that we can use drug class to get similar sensitivity and specificity. So it does work pretty basically as well, but we do still have a really high false positive rate. So we still have a lot of people in the low risk group who are having events, but we can at least generalize the PROACT model and get similar results for ease of use. And then, so our next steps with this is to include comorbidities and socio-demographic data. And hopefully we would get some of these we would be able to identify the patients in the low risk group that may actually be at high risk, but they're at risk due to their own demographics and comorbidities. So now I'm going to take a quick turn of events, and we're going to go to timely treatment. So delays in treatment are associated with worse patient outcomes, and tumors may increase in size between symptom onset, diagnosis, and treatment. And we also know that care delays are associated with a worse prognosis and happen disproportionately higher in underserved and disadvantaged populations. So if we can start to measure and potentially prevent treatment delays, we can obviously help patients quite a bit. So we're going to look at overall delays, even though there's lots of different time points and intervals at which patients can experience delay, we're going to look at overall today. And there's two different ways we can measure it. One is a prospective measurement where we say, yes, you have received care within 30 days, or no, you have either not received care in 30 days or you've not yet received care. So we could potentially intervene. And then retrospectively, we can look at time to treatment as a count of days between diagnosis and treatment start. So we're going to start looking at this retrospective time to treatment, which is actually how we started. We started looking at time to treatment, and then kind of at the last minute realized that timely treatment would maybe be a little bit better metric, and we'll get to that in a minute. So patients take different paths to get to their treatment. And so we're trying to, with time to treatment, we're trying to find, we use the Pareto rule to try to minimize the amount of effort, but maximize the number of patients that we'll be able to include in the analysis. But that does mean that we have to make some exclusions because essentially we're looking at a continuous variable that's easily, we don't want to skew the mean or the median because there's patients with very large time to treatments. So we're starting with patients that have received chemotherapy, radiation, or surgery for their cancer, and then we're going to look back to the start of their cancer journey. The problem is that we don't have a good diagnosis date. And so there's a lot of different fields in the EHR that you can use to start the clock, but there's missingness or it's incomplete data and not recorded standard across all departments. So we actually decided that the new patient encounter to oncology, so it's like their first visit to oncology, is the best place to start the clock. And so we start by looking for the treatment here in this green dot, and then we look back to the first new patient encounter, and we count the days in between. So we have to, as I alluded to before, we have to make some exclusions because we want to have an accurate metric for this population. So here are a thoracic patient population where we started with 767 patients. And then at our first step, we excluded the patients that had no new patient encounter. And these were patients that on chart review, we found had been diagnosed in their inpatient hospitalization or were at the emergency department. And so they had an inpatient oncology consultation. And then our next step of exclusion is we excluded patients with very high time to treatment metrics. So these are probably patients who have been on active surveillance for a long time. And so they haven't received treatment because that is the appropriate course of action for them. And then we also excluded the patients with the new patient encounter after the treatment starts. So we go from 767 patients down to 445 patients, or 58% of the population. We can calculate this days of time to treatment. And here is just kind of how it looks. On the left, we can see this is everybody, and on the right is who we included in analysis. And you can see that we kind of cut off the distribution is quite skewed right, and so we cut off a lot of that tail, and then also all of the people with negative time to treatment. Now, so as I alluded to before, we actually realized that timely treatment is a dichotomous measure. Whether or not a patient has or has not received care within 30 days is a little bit better. We found that this, gives a lot more credit. If you move a patient from, say, 34 days to 29 days, that is an improvement to get them under 30 days. Whereas if you move them, and you get a lot of credit for your metric. Whereas if you're trying to move a patient from 45 days to 39 days, in a continuous measure, you would get the same, generally the same credit, but we're not really helping patients when we know we need to get them into treatment within 30 days. So now we can also use this as kind of a report where, so if I was looking at this, I would be able to immediately identify which patients are receiving delayed treatment and potentially intervene to reduce further delays. Or I could see these patients who are at risk, these yellow patients, and then make sure to follow up with them to make sure that they get their treatment as soon as possible. And then I can also see who has received treatment in a timely manner. It's also important to note here that not all patients that we have their first visit end up having their treatment at UNC Health. Some of these patients are coming for second opinions, or treatment is not actually the appropriate thing. It's more appropriate to do watchful waiting or continued surveillance. And so we actually kind of have a ceiling of about 55% of the patients who ever have a new patient visit end up having treatment. So if we can look at how the data roll out, and we can see that within the thoracic patients, those that receive radiation have the shortest delays, and surgery patients have the longest delays. And you can also see like we have to exclude a lot more patients from the metric in the retrospective time to treatment. But our governing structure has approved of timely treatment. And so that is the metric that will be going into production sometime next year.